This is Dr. Jack Bert. I'm going to be giving a talk regarding employer to provider contracting. How does it really happen? And just as a brief background, I've been in practice for 40 years. I began a company called MD Direct, which basically you'll see has done some early work utilizing employer to provider contracting. I want to share with you our results because I think that this is going to be the type of reimbursement and relationships we're going to have with employers in the future. So understanding that is a conflict. The remainder of my conflicts are in the AAOS website. So if we look at, from a background purpose, the number of insured individuals in the United States in a population of 325 million people, about 182 million are commercially insured, which means they're employer-based. About 62 million are on Medicaid, 56 million on Medicare, and about 28 million are uninsured, and the rest are on military insurance. If you look at the health insurance costs, as evidenced on this particular slide from the U.S. Bureau of Labor Statistics, since August of 2018, health insurance costs have skyrocketed to the point where it's virtually over 20% of the GDP. And in the National Business Group on Health, it's called the NBGH, they actually publish every year a healthcare strategy and plan design survey. And this is conducted from May of 2019 through June of 2019. This particular group consists of 170 large employers, 60% are Fortune 500 company individuals, and the healthcare costs they've noticed are increasing from 7 to 9% per year. Of interest is last year, General Motors spent more money on healthcare than steel and aluminum to make cars, and the estimated cost per employer by 2020, which is basically in January of this year, is $20,000. And so next year it's supposed to go up to $21,000, with about $5,000 of that being the employee deductible. So what's really interesting is if you look at the total annual premium and employee contribution, the most popular plan, Kaiser noted this as well last year, that it was about $19,000 for family and about $6,800 for an employee. So if you look at the family and premium cost per employee, it's about $21,000 and $5,700 for a family with the employee contribution. So again, this reinforces the fact that it's over $21,000 or $20,000 to $21,000 per year. This is from the National Safety Council in 2019. And what you can see is the average cost for work comp injury, including the lost wages, replacement work and care costs, about $40,000, which is ridiculous in terms of cost for the employer. So by way of background, also, you need to know who makes decisions regarding healthcare insurance vendors or self-insured programs for employers. And 78% of organizations work with a broker or consultant, which is really interesting because over 70% of respondents have not switched brokers or consultants in the last 3 years. So the critical question asked is how much of employer healthcare spend is musculoskeletal? And if you look at the data, and this is published in the Journal of the American Medical Association, it's about 10% musculoskeletal care injury compared to diabetes, mental health, cardio, maternity, neoplasms. And what's fascinating is mental health actually is second, which we all know is huge with respect to orthopedics. Here's a claim summary that we actually did a sample from a Fortune 100 company, and you can see the medical costs for low back pain per surgery is $92,000. A meniscal tear is actually quite significant. It's over $30,000. And if you look at shoulder scopes, for example, at $48,000. So you can see that the medical costs are outrageous for a lot of the procedures that we normally treat. So why is the spend so high? Well, here's an actual claim example of a knee injury in a distribution center worker, and you can guess which company this is, but I've got 22 of these that I've analyzed. And the problem is what happens to most of these workers is they go to the primary care doc, and what happens then is they go for physical therapy, they get addicted to narcotics, and as you all know, the FPs are the #1 mismanagers of opioid use and have the highest incident of chronic addiction for patients. Orthopedics is third, interestingly enough. And they don't get to the orthopedic surgeon till day 111. Diagnosis is made, and this particular individual went back to work at day 122, 11 days after seeing the orthopedist, and this was a simple grade 1 MCL sprain. So you can see how ludicrous this becomes. And the cost of care, including workers' comp reimbursement, care expenses, replacement workers' salaries, about $31,000 for this particular individual. When we look at claims analysis results, we found that 40 to 50% of the cost of care is due to delays in treatment, prolonged conservative care, consisting of physical therapy, chiropractic care, opioid dependence, and the high ancillary referrals. For example, in this particular pilot study, we found the MRI costs were between $3,000 to $5,000. So there's outrageously high inpatient service costs, which affects self-insured employers as well. And then the replacement workers' expenses are significant for workers' comp. So when we looked at this data, and this was from the employer's perspective, and they reported this in their annual meeting, healthcare spending was truly out of control. Brokers control the employer's healthcare decisions. Employers have an appetite for direct contracting at this time, and musculoskeletal spend is the #1 healthcare expense. Almost all employers are moving to a self-insured model, and so the employers are responding as follows. What they found is they've decided to go to a self-insured program. So you can see what happens here. All employers over 5,000 employees are 100% self-insured, and 61% of employers nationally are self-funded, even with less than 250 employees. These are some examples in Minnesota of self-insured employers such as Cargill, Best Buy, Wells Fargo, 3M, and it goes on and on. So you can see that this has become very, very common throughout the states. If you look again at this annual report, direct contracting with providers for specialty services has been seen as very effective, while direct primary care models have not. So you can see why the model is now going to specialty services. So what are employers doing to reduce costs? They're doing direct contracting with specialty providers, but it's less than 1% nationally, using nursing assist phone lines to avoid ER visits, with some attempts at virtual solution, less than 20% utilization, on-site or near-site clinics, which have become very popular, switching to value-based payments and seeking providers that will initiate value-based programs such as bundling. So quality equals outcomes over costs, and you can see this is true at this particular publication, and this is with Walmart using featured providers. And what they found was that consistent quality care based on data from public and private insurance programs has worked well for Walmart. So what do brokers, third-party administrators, and cost management companies actually really do for employers? A broker sells insurance products, including health plans, to an employer, which hopefully serves the needs of his employees. Brokers have a variety of payment models ranging from per member per month fees to a percentage of healthcare claims. The third-party administrators process the company's healthcare claims. They manage all the employer-employee contributions for healthcare. However, the employer technically owns all the claims data if they use a private group. This is very, very difficult claims data to obtain from an insurer, because they really don't want to share that. So the self-insured owns the data, fully insured, the insured owns the data, and the employer has no clue what the actual costs of care are. So for example, let's say that the employer decides to utilize an insurer such as United Health Group. United Health Group tells the employer that the premium dollar per employee is $12,000. The employer at the end of the year has no idea how much of the $12K has been spent, retains the profit. I could tell you story upon story about claims analysis, which we have done, where only maybe 6,000 of that is utilized and the rest goes to the insurance company's profit. And that's why United Healthcare will probably make $100 billion in 2020. They made $87 billion last year in profitability. So you can see how outrageous this can become. So the ideal scenario for the employer is a self-insured plan. The broker packages cost savings products. The savings are returned to an employer. The worst outcome is that it's a fully insured plan. Broker collects a huge commission for selling the plan to the employer. The insurer makes a significant amount of profit. The employer has no clue what his actual healthcare costs are or where the money went. So, can employers directly manage musculoskeletal costs? Well, the answer, quite honestly, is choosing a high-quality orthopedic group defined as having good outcomes at a low cost that is willing to agree to a bundled payment with 90-day global coverage. Now, what we found is we have made agreements with low-cost MRI units, and there are 5 in Twin Cities of Minneapolis, St. Paul, and Western Wisconsin. They vary between $490 and $690, whereas you can actually find MRI costs as high as $5,000. So you can just see, just in imaging, the employer savings can be significant. So let's go back to that one case I showed you. And if you got rid of that entire left-hand side, went right to the orthopedist, did an MRI scan, a low-cost one, made a determination, had some 2 to 3 days of physical therapy, setting the employee back to work, you can see that the dramatic cost savings are occurring. So let me go back to what we've done. We've done pilot study of 2 employers representing 4,000 employees. We have immediate subspecialty involvement with a patented questionnaire and process that we have developed and utilized for the past year. We have experienced orthopedic surgeons on our staff with a minimum of 35 years of experience contacting the patient after reviewing the questionnaire and patient data. We exhaust conservative care, including nonsteroidal short-term PT with a home program, injectables, optimization protocols, including weight loss, especially prior to total joint arthroplasty. And we use a cost-effective ancillary service for diagnostic and treatment. So if you have an orthopedic group for surgery willing to take on risks that have agreed to bundle payments for a surgical procedure, including a 90-day global period, they agree to specific surgical guidelines, BMI control, comorbidity risk, appropriate conservative care, and then use stop-loss first dollar coverage insurance included in the bundle so that if they do have a complication, that's covered so that you can avoid these bundle busters or what we call avalanche cases that occur from readmission. Then you get dramatic savings, and the brokers and third-party administrators and employers are all in utilizing this concept. What we found was immediate care management is the key. When we apply these concepts using patient questionnaires, bundle payment, package pricing, conservative protocols prior to surgery, cost-effective ancillary services, immediate subspecialty, patient contact by one of our orthopedic surgeons using this patented questionnaire, the results in our pilot program were as follows. This is the average healthcare expense by diagnosis in one of the pilots, and they had 1.9 million in musculoskeletal expense out of 9 million total. So it's virtually about 20%, a little bit over 20%, 22%. And you can see the rest of the costs as you go down the line here with digestive system, cancer, et cetera, et cetera. And you can see that musculoskeletal costs were significant. This is what we actually found in this one pilot that happened to be in an area that had very, very high private group expenses that didn't do bundles, 2 large clinics that charged $48,000 to $50,000 for total joints. We actually resulted in a 55% savings in the first 6 months with 4,000 employees. So here are the conclusions of this particular program. And these are the recommendations that we have. More employers are demanding cost reduction strategies. Brokers, third-party administrations, and cost management companies are seeking partners that can provide savings. We work through the brokers, third-party administrators, and the cost management companies because they have the true relationship with the employers. Musculoskeletal care is the largest single healthcare expense for employers, and orthopedic surgeons are positioned perfectly to provide efficient, cost-effective care if they're willing to take on risk, which can easily be managed with stop-loss policies and aggregate insurance. So we've now added 10 more employers representing about 70,000 employees beginning a pilot study on 6/1/2020 to hopefully reaffirm these findings on a much larger scale. And we'll be happy to report the results of this to us, but we're convinced that we can really help out employers utilizing this technique. Thank you very much for your time, and I'm more than happy to take on questions at some point. You can contact me via email at bertx001@gmail.com. So that's BERTX001@gmail.com if you have any questions.